Hello everybody, I'm back. Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania, past National President, IMA, and President, Heart Care Foundation of India. And you are watching Med Talks with Dr. K.K. Agarwal, non-stop 161st episode on COVID. Let's have the headlines of the day. Historic day in virus fight. European countries, including Germany, Italy, and France, kicked off their vaccination campaign as a growing list of countries have identified their first case of coronavirus mutation widespread in the UK. Meanwhile, the virus strain was also found in a Canadian couple with no travel history. Matter of concern, that means the disease is already there. India reports 18,732 cases, lowest spike since June. Maybe India may settle down its spike at between 10,000 to 20,000 as a plateau. India's cumulative recovery stands at 95.78%. All state and UTs have a recovery rate of over 90%. Russia allows domestically designed COVID-19 vaccine for people over 60 years of age. Before we go to the topic of the day, let's have our ritual of washing our hands. We take the Ultra Protect Gel, works for 2 hours, and let's say S for Seetha, U for Ulta, M for Mutti, A for Angutha, N for Nakhun, and K for Kalai. Once we have done that, we are ready for the topic of the day. So we are going to interact with the life of a surgeon during COVID-19. And the surgeon is none other than Dr. Ashok Gupta, a Padma Shri awardee, a senior consultant plastic and reconstructive surgeon at Bombay Hospital Institute of Medical Sciences, won several international social awards, including the Sheikh Hamdan International Award, Queen Victoria Commemoration Medal and Award, Lifetime Achievement Award for Health and Philanthropy at United Nations, and many more. He has been a member of the Board of Governors, Medical Council of India, and Academic Council, Maharashtra University of Health Sciences. Welcome, Ashok ji.
Thank you, Dr. Agarwal.
पहले आपने सुना कि कोरोना आया है, what was your first response?
देखिए, कोरोना जब आया तो it came with a big challenge as a surgeon. I mean, all of us know the surgeon and surgery is something which cannot be handled by telemedicine or advice on video or advice on remote control. So it was a big challenge to all of us as a surgical community, how to cope with the corona and how to cope with the patients who are either positive with corona or who are suspected to have corona. Then there was a lot of thinking going on all over the world, a lot of planning and a lot of assessment. And basically, most of the surgical community were advised to first to delay or postpone all the elective surgeries, which are, I mean, in my specialty, there was nothing, very few limited things which were called as a emergency surgery or which could not have been delayed. So first and foremost thing was to delay all surgery or postpone all emergency surgery or planned surgeries. And thereafter, then things started coming back. And our own hospital, at Bombay Hospital, they made some policies. They reviewed the entire situation of COVID and COVID patient and planned everything. And I would be very happy to share some of the statistics which has been worked out by the international group of surgeons, which is called as a COVID Surge Group. And I will like to share some of the thought through that. And I think during this COVID time, what we have learned as a surgeon is to moving forward. COVID is a big challenge to all healthcare professional as well as the patients and hospital establishment. And how to cope up with the challenges and how to move forward has been a big challenge. It has brought the pandemic has given rise to feeling of fear, anger, and helplessness amongst practically all walks of life. The virus has changed the outlook of surgeons to provide care and as well as also to cope with the financial distress which is involved with the institutional based practice as well as the people those who are in private practice or running smaller establishments. So it has been a big challenge as a surgeon to cope up not only for the self condition but also number of people those who are dependent on my surgical practice, which include the anesthetists, which include the assistants and the nursing uh, and other paramedics who are involved with the surgical care, etc. So I think it's a big challenge in the life of a surgeon. Now I had shared some slides. Would you like me to share some PPT or
Yes.
share slides? Can I share slides? Ritu,
Ritu?
can you share slides?
Ritu? Yes.
Go to next one, Ritu. Next slide. Yeah, this. I mean, my specialty involves so much of close contact doing microsurgery, where so many people work in a small zone. So it was the most dangerous type of surgery to perform on COVID area. It is a surgery which lasts almost for 8 to 10 hours of time. So that was also another contraindication. Next slide. Next. The COVID-19 pandemic has had a substantial effect on surgeon and patient who require surgical care. Providing care for patients with surgical disease require a unique and intimate relationship between patient and surgeon, and which I mentioned, this interaction and contact cannot be replaced by telehealth or other modes of healthcare provisions, etc. Next, the financial implications of surgical shutdown has been far-reaching. Many private practices could not stand the financial challenges of pandemic and are being forced to shut down. Some of the surgeons have retired early or decided to leave the surgical profession. I'm in very sorry state of affairs for them. And all of these problems further influence the surgical workforce in the time during which there is likely to be greater need for surgical care. And even in our own hospital, most of the senior specialists who were coming in the risk with a morbidity, etc., have preferred to stay home rather than attending the hospital. So expertise care were probably not available to some of the challenging issues. Next. I mean, it goes without saying that surgical care is the foundation of health system with both elective and emergency procedures and are contributing to the essential health services of our population. There are situations where there is no option apart from surgery. So it is obligated to act thoughtfully and to support the hospital surgical care as well as protecting patient and staff as well as to conserve the resources which are available with our hospitals. Next. How I mean, the big challenge for most of the surgical community was how to adapt to the new normal. Now, it has practically become a new normal over the last 9 months. We have gradually accepted the term, and which has become a new normal now. How do we uh, change our practices, surgical practice during COVID era? First and foremost was prepare for a rapidly changing situation. Every week we see there are new development, new things which are happening. Postpone elective surgeries immediately. Develop dedicated operation suites so that there's hardly any mixing between the patients with a COVID positive or COVID negative. And also to be considered how long the surgery likely to be and whether patients will be required ICU care after the surgery. And these two factors was the most influencing factor in decision making for surgery. Next. Subsequently, also, will the patient be needing ventilator during or after the surgery? Will there be major blood loss during surgery? how many number of surgeons and nurses needed to perform that operation, and is this surgery is likely to be in low risk group or in the high risk group. This triage has been suggested by the American College of Surgeons, and most of the surgeons across the world are guided by this triage, and which is very helpful in deciding when to perform surgery and which group to be given preference for performing surgery. It's a very useful link. Next. At the million dollar question between the patient and surgeon was, is it worth taking the risk? Are we uh, are we calculating the risk benefit ratio by doing surgery? And this is a very interesting study which has been done by a group called COVID Surge. It's a global study published in October 2020 by a group of hospitals, including the Harvard and some other leading universities. And the statistics are not very encouraging. It reads that for every person who undergoes surgery during the COVID-19 pandemic, 1 in 4 chances that they will die, and there are 50% chances that they will suffer severe pulmonary complications either during surgery or after surgery. Next. Benefit of creating COVID-19 free uh, zone within the hospital was recommended by them. And COVID-19 positive are not mixed in the area, thereby minimizing the risk of accidental exposure to the virus. And COVID-free zones must be established to protect patients opting to undergo elective surgery during the pandemic. And this is being followed by most of the leading hospitals in the world, including India and including my own hospital in Bombay. Next. COVID surge has expanded its participation, doubling the number of hospitals and tripling the number of countries. At present, there are 733 hospitals across 73 countries, and more than 24,000 patients have been enrolled for this study. And the information is invaluable, and everyone wants to have detailed study of the risk-benefit ratio being shared. And this is the major guiding source of information which is being created by COVID surge. Next. Surgeons didn't have any information about how COVID affects surgical patients. Current study tracked more than 1,100 patients who underwent surgery. About 75% had emergency surgeries and 25% had elective surgeries. The study also was shared in Lancet, which shows impact of COVID on patients testing positive for the virus 7 days before or 30 days after the surgery. And this is next. And in this, it was also 1 in 4 patients infected with the virus before or after surgery died. Very, very discouraging. 1 in every 2 patients contracted serious pulmonary complications such as pneumonia, acute respiratory distress syndrome, or unexpected post-operative ventilation. Type of anesthesia used, whether general, regional, sedation, or local, didn't matter in the outcome. And it reminds us that COVID is not only a lung disease, it touches practically all other system of the body. And surgical decision of uh, electing to perform surgery has to be critical and keeping all these factors in mind. Next. It is a very good guideline of triage, which has been, as I mentioned, proposed by the American College of Surgeons. Hospitals and outpatient surgery centers should consider their patients' need and logistic capability to fulfill their real time. Need for a procedure should be established by a surgeon with expertise in the relevant surgical specialty to determine the damages uh, to, to be sustained by delay in undertaking, and feasibility of procedure to be determined by administrative persons for accepting considering hospital facility safety and well-being of the treating staff. Next. The risk of patients should include an aggregate assessment of the real risk of procedures and the real risk of delay. Finally, COVID-19 is a clear risk to all, and it is but one of the many competing risks for patients requiring surgical care. Surgical procedure should be considered not based solely on the COVID-19 associated risk, but rather on an assimilation of all available medical and logistic information, including comorbid conditions and other factors also. Next. I think safety in operating room was very important factor, and although we were taking several protocols to follow during the surgery, and safety issue in operating room using N95 masks, face shields, eye protection, and double layer of PPE are common practices. More for any surgery around the airway, nose, neck, mouth, anal region, or intestine, which are uh, heavily contaminated in case of COVID positive patients. Sometimes patients are so sick that we need to perform surgery in ICU, and that may not be so sterile, and then again we have to follow extra precautions. And for a surgeon, it becomes such a big task to wear double PPE kit, wear a mask, wear a face shield, eye protection, and continue to perform surgery for more than 2 hours or 3 hours uh, is a real task. And sometimes surgeon himself may not uh, be able to sustain the pressure of performing surgery. Next. It is also recommended that there should be universal use of smoke evacuation to suction away the smoke plumes generated by cartridges which are used during the surgery, etc., and to minimize the risk of exposure to aerosolized tissue more for the people paramedics working there. Precautions should be also taken to surgical cases, particularly for minimal invasive procedure that requires creation of a pneumoperitoneum and must be safely managed to avoid and to be avoided if possible, because that also can increase the risk of spread of the virus during intestinal surgery. Next. The biggest shock from this study is that the patient may survive the surgery but still has got a higher risk of developing serious complications or even death than there was before the pandemic. And this, we know that all surgeries carry a 2% risk of complication from anesthesia, post-operative recovery, etc. But with COVID, this has increased many a times. Impact of COVID on post-operative pulmonary complications and mortality needs to be established to enable surgeons to make evidence-based decisions. And a study like COVID Surge is a very vital source of information for all surgeons to make a proper decision. Hospitals also need to be guided by this study. Next. As a matter of routine practice, a patient is always informed about the risk before the surgery. But now we are letting them know their risk even greater. There's a special consent which needs to be uh, sought from each and every patient undergoing surgery. We're giving full details of the potential risk because of the COVID. And as said, no system is foolproof. Transportation to and fro from the rooms and elevator, post-operative room, etc., can transmit infection. And patients to quarantine for 30 days after the surgery and not to have any contact with anyone, even if it is most minor or a relatively minor procedure. I think there are a few very important tips which, as a surgeon, we must follow during the COVID era while performing surgery. Our training has been affected. We are not able to train our residents efficiently. The teaching has been affected. Most of the time, we are converting into virtual teaching forum. So, hands-on training, hands-on teaching has been affected during the COVID era. Next. And with these few points, it's a pleasure to join the Med Talk with Dr. K.K. Atwal, and I'm sure there could be many other issues with the surgical care and challenges to surgeons.
So thank you, Ashok ji, to be here. So I'll have a 15 minutes quick chat with you. सबसे पहले my question is, जब आपको पता लगा कि कोरोना आया है, तो सबसे पहले आपको डर क्या लगा? Forget about as a doctor, as Ashok Gupta. डर लगा, हिम्मत आई, और you would say it's okay.
सबसे पहले तो इट वाज अ बिग शॉक जब हमको पता लगा कि कोरोना एंडेमिक से पैंडेमिक हो गया. सभी लोग वे ऑल वे टेकन ऑन ए बैक फुट. And being a senior consultant in the hospital, our recommendation to the hospital was stop all elective procedures, wait till situation settles down, wait till our hospital gears up uh, to protect the paramedics, this treating the hospital staff as well as the patients. And हमने तो अपने तरफ से पूरा ये decide कर लिया with the age which is 60 plus with the comorbid conditions. It is better to stay away from the potential patients and surgery rather than indulging into the and taking a risk and spreading the risk of infection to other patients also.
जब आपको पता लगा कि बॉम्बे में यू आर लूजिंग डॉक्टर्स आल्सो, तो उस वक्त में क्या लगा?
यस, बड़े दुख की बात है कि मेरे खुद के कलीग्स जिनके साथ में मैं जब बॉम्बे वापस आया, जब मैंने प्रैक्टिस शुरू की थी, उसमें से 2 ऐसे लोग हैं, वो सकम हो गए इसको, कोविड को। मेरे जो बिल्कुल शुरुआत हमने जो शुरू की थी, बिल्कुल हमारे साथ में जो हमने हजारों सर्जरी साथ में की, उन्होंने या तो प्रिकॉशन नहीं लिया या थोड़ा सा रिस्क लिया और अननेसेसरी उनका जो इतना एक्सपीरियंस है वो किसी काम में नहीं आया।
क्या आपको लगता है कि अब समय आ गया है नॉर्मलाइज होने का या सेमी नॉर्मलाइज होने का?
बिल्कुल, देखिए 8 महीने में हमने बहुत चीज सीखी है। 8 महीने में सर्जन्स को क्या करना चाहिए, कैसे प्रिकॉशन लेना चाहिए, किस प्रकार की सर्जरी करना चाहिए, ये लगभग पैरामीटर्स एक्सेप्टेबल लेवल में पहुंच गए हैं। सभी यूनिवर्सिटीज में, सभी हॉस्पिटल में हमने खुद ने अपने आप ये प्रोटोकॉल फॉलो करने की कोशिश की है। और ये समय आ गया है कि यदि हम सही तरीके से पेशेंट्स और सर्जरी को चुनेंगे और अपने आप प्रिकॉशन लेंगे तो सर्जरी परफॉर्म की जा सकती है विद लिमिटेड रिसोर्सेस।
और ये आपको लगता है क्योंकि अब हम कहते हैं कि ये वायरस 9 दिन में मर जाता है, so even if your illness persists but the virus is not alive, so there should be a campaign that hospitals should say that अगर आपके 10 दिन पूरे हो गए हैं तो we will treat you as non-COVID unless they are very highly immunocompromised.
नहीं, हमारा एज ए सर्जन हमारे इशू थोड़े से अलग हैं, क्योंकि सिर्फ ये वायरस के कारण कॉम्प्लिकेशन नहीं हो रहे हैं, लेकिन वायरस के बाद में जो आफ्टर इफेक्ट है लंग्स में, इंटेस्टाइन में और जो इम्यून जो सिस्टम में थोड़ा आता है, उसके कारण कॉम्प्लिकेशन रेट बहुत ज़्यादा है, पर्टिकुलरली एनेस्थीसिया का। मोस्ट ऑफ दी सर्जरी जो हम लोग करते हैं जो 5 या 6 घंटे चलती है, उसमें रिस्क ऑफ कॉम्प्लिकेशन, पल्मोनरी कॉम्प्लिकेशन बहुत ज़्यादा है। कुछ प्रकार की सर्जरी जिसमें वर्ष से उसमें पल्मोनरी एम्बोलिज्म के चांसेस हैं, उस सर्जरी को यदि परफॉर्म करें तो हमको ऐसा लगता है कि इसके ड्यूरिंग कोविड एरा उसके चांसेस बहुत ज़्यादा बढ़ जाते हैं। तो उस वैसे सर्जरी में प्रिकॉशन लेना पड़ता है। बाकी तो सर्जरी जो 2 घंटे या 3 घंटे में हम परफॉर्म कर सकते हैं जिसमें पोटेंशियल कॉम्प्लिकेशन नहीं है, उसको हम जरूर अभी नियर नॉर्मल तरीके से परफॉर्म करना शुरू कर दिया। तो एक समय में हमारे हॉस्पिटल में लगभग रोज की 100 से 150 सर्जरी हुआ करती थी। ड्यूरिंग कोविड वो रिड्यूस होके 10 या 15 पे आ गई। अभी फिर से वापस लगभग वी हैव गॉन टू अबाउट 50 to 70 सर्जरीज पर डे।
तो प्लास्टिक सर्जरी में लगता है कि जो रूटीन सर्जरीज होती थी नॉन एसेंशियल, ओनली फॉर द कॉस्मेटिक पर्पस, कि मेरे को झुर्रियाँ हटा दो, मेरी ब्रेस्ट को रिस्ट्रक्चर कर दो, तो वो लगता है आपको कब तक नॉर्मलाइज होंगी कि नहीं होंगी? ये पब्लिक का परसेप्शन चेंज हो जाएगा कि छोड़ दो?
नहीं, वो सर्जरी तो खैर देखिए अभी टाइम बीइंग तो लगभग नहीं के बराबर है। बहुत कम पेशेंट्स हैं, क्योंकि फेस सर्जरी करना है तो उसमें 4-5 घंटे लगते हैं, फेस का है तो वो लगभग नहीं के बराबर है। लेकिन दूसरे जो अल्टरनेट मेथड है, नॉन सर्जिकल ऑप्शन है, वो काफी तरीके से चल रहे हैं। पेशेंट्स भी अपने आप ऑप्ट करते हैं, सर्जन भी ऑप्ट करते हैं। सो सर्जरी में हमेशा ऑल्टरनेटिव अवेलेबल है, तो ये चीजें तो चल रही है। लेकिन जो एसेंशियल पार्ट है प्लास्टिक सर्जरी में, जो बर्न्स हैं, जो एक्सीडेंट के केसेस हैं, जो कैंसर रिकंस्ट्रक्शन है, जो दूसरे टाइप की, वो हम बराबर अभी फिर से लगभग चालू कर दिया है, उसमें कोई प्रॉब्लम नहीं है। वो लगभग
क्या होगा मेडिकल स्टूडेंट्स का जो एमएस सर्जरी करेंगे या जो प्लास्टिक सर्जन्स बनना चाहेंगे, तो उनका इस पीरियड में क्या होगा? एक्सपीरियंस तो मिलेगा ही नहीं उनका, देन हाउ विल दे लर्न?
एक ये सबसे बड़ा चैलेंज था कि जितने भी सर्जिकल रेसिडेंट्स थे ड्यूरिंग कोविड टाइम, हॉस्पिटल में सबको कंपल्सरी रोटेशन आईसीयू में भेजा गया था। तो उनको सर्जिकल एक्सपोजर जो होना चाहिए था टाइम का, वो सर्जिकल एक्सपोजर छोड़ के उनको नॉन सर्जिकल उसमें गया। लेकिन एक प्रकार से वो भी लर्निंग प्रोसेस था, कैसे आईसीयू के पेशेंट को हैंडल करना, कैसे पेशेंट को मॉनिटर करना, कैसे पेशेंट को रिवाइव करना। दैट वाज ए बिग एडिशनल हेल्प। लेकिन सर्जिकल जो ट्रेनिंग है, मुझे ऐसा लगता है कि ये कोविड पीरियड को ओवरकम करने जो लॉस है, इसके लिए या तो उनको 6 महीने एक्स्ट्रा कहीं सर्जिकल रेसिडेंसी करना चाहिए, या 6 महीने एमएस के बाद में या एमसीएस के बाद में 6 महीने थोड़ा और एक्सपोजर करना चाहिए, तभी उनको ये कंपनसेट हो सकेगा। इट्स अ बिग लॉस जब हम हैंड्स ऑन ट्रेनिंग नहीं दे सकते उनको।
आपको लगता है 24 मार्च तक हम लोग कोरोना को कंट्रोल कर पाएंगे कि नहीं, द फर्स्ट एनिवर्सरी ऑफ लॉकडाउन?
ये तो इज अ $1 मिलियन क्वेश्चन। आप लोग ज्यादा बता सकते हैं एज ए फिजिशियन, लेकिन एज ए सर्जन हमको लगता है कि इसको नियर नॉर्मल आने में लगभग कम से कम मिडिल ऑफ 21 जून या जुलाई 21 तक ही ये फिर से नॉर्मल स्टेज में, सर्जरी जो फैक्टर है नॉर्मल स्टेज में शायद आ सकेगा।
अगर आपको पर्सनली चॉइस मिले कि सारे वैक्सीन अवेलेबल हैं आपके लिए, तो आप कौन सा लगवाएंगे और क्यों? पहले तो लगवाएंगे कि नहीं, और लगवाएंगे तो कौन सा और क्यों?
खैर अभी तो मैंने सोचा नहीं है, लेकिन यदि लेने की बात हुई तो जैसे जो अवेलेबल है इंडिया में, या फाइजर जिसके बारे में सब जगह चर्चा चल रही है, वो गो फॉर इट। और बाकी तो खैर जो बाकी जो डिसीजन मेकर्स हैं वैक्सीन के बारे में जो रिकमेंड करेंगे। लेकिन अभी मैं थोड़ा सा इमीडिएटली आई डोंट वांट टू जंप, मैं थोड़ा सा वेट करके देख के कि बाकी लोगों का क्या रिस्पॉन्स है, किस प्रकार से म्यूटेशन हो रही है, किस प्रकार से नए स्ट्रेन आ रहे हैं, और ये वैक्सीन उसमें हमको सफिशिएंट प्रोटेक्शन दे पाएगी कि नहीं दे पाएगी। और जो दूसरा जो फैक्टर है कि जो वैक्सीन भी है ये लिमिटेड इम्यूनिटी है, इट नॉट गिविंग ए टोटल प्रोटेक्शन फॉर एवरी टाइप ऑफ कोविड वायरसेस। तो वो थोड़ा ऑब्जर्व करके
आज की डेट में तो वैक्सीन म्यूटेशंस के बाद में तो और जरूरी हो जाता है जल्दी लेना। क्योंकि अगर आपने वेट किया, मान लीजिए म्यूटेशंस आएंगे तो वैक्सीन तो उस म्यूटेशन को भी रोकेगा ना। अगर इस वक्त में अगर हमने वैक्सीन को वेट किया, आई डोंट थिंक सो इट इज एडवाइजेबल टू वेट फॉर द वैक्सीन। दिस इज द राइट टाइम टू टेक द वैक्सीन।
आई एग्री विद यू।
तो उसके अलावा आपकी फैमिली का क्या रिस्पॉन्स रहा कोविड में? Because of a doctor person in the family, were they relaxed or were they in fear or they were forcing you मत जाओ कुछ मत करो?
नहीं, ये तो खैर फैमिली के सभी मेंबर का था कि आपने बहुत काम कर दिया, 50 साल से सर्जरी कर रहे हो, अब थोड़ा स्टॉप करो और घर में से काम करो जो कुछ करना है। तो वो एक प्रकार से वो टाइम यूटिलाइज करने का मौका मिला। कुछ साइंटिफिक पब्लिकेशन किए, कुछ बुक में चैप्टर लिखे, कुछ ऑनलाइन टीचिंग किया, कुछ वेबिनार्स किए, कुछ सोशल सर्विस काम किया, कई प्रोजेक्ट थे जिसको एज ए सर्जन एडवाइस किया। लेकिन जो एक सर्जन का सबसे बड़ा पनिशमेंट है, टेक अवे द नाइफ फ्रॉम द हैंड। सो आई फील पनिश्ड फॉर लास्ट 6 months that I'm not able to perform my passion, which is surgery, and I'm looking forward to go back to operation theater, wearing my mask, wearing my holding knife in hand and teaching my students. That's a big passion for a teacher and as a surgeon, and I'm really looking forward for that.
So याद रखिए कि डॉक्टर अशोक गुप्ता ने क्लियरली कहा है कि जब कोविड पीरियड में सर्जरी इम्पॉर्टेंट नहीं है, इम्पॉर्टेंट है अगर कोविड इरा में आपको कोविड हुआ है और आपकी इम्यूनोलॉजिकल इन्फ्लेमेशन खत्म नहीं हो, आपकी प्रो इन्फ्लेमेटरी एंड प्रो थ्रोम्बोटिक स्टेट जब तक नॉर्मल नहीं होगी, तब तक सर्जरी कराने में और एनेस्थीसिया देने में खतरा है। यानी कि जब भी आप पूछो, सिर्फ ये मत पूछो कि मेरा कोविड ठीक हो गया है, आपने ये भी पूछना है मेरा प्रो इन्फ्लेमेटरी स्टेट ठीक हुआ कि नहीं, और मेरा प्रो थ्रोम्बोटिक स्टेट ठीक हुआ कि नहीं। ऐसा तो नहीं होगा सर्जरी से मेरा इन्फ्लेमेशन प्रेसिपिटेट हो जाएगा, या सर्जरी से मेरा क्लॉट्स प्रेसिपिटेट हो जाएंगे और मेरे को पल्मोनरी कॉम्प्लिकेशंस हो जाएंगे। और मुझे ये भी देखना है कि पोस्ट कोविड फेज के अंदर में कोई रेजिडुअल मेरे को पल्मोनरी फंक्शंस खराब तो नहीं हुए हैं। उसके लिए मेरे को डिफ्यूजन कार्बन मोनोऑक्साइड का DLCO टेस्ट भी दिखाना है कि मेरे लंग्स बिल्कुल नॉर्मल है। और सिंपल टेस्ट CRP <1, माइक्रोएल्ब्यूमिन नेगेटिव, and 500 meters walking in 6 minutes. ये 3 टेस्ट अगर आपके नॉर्मल आ गए कि आप 6 मिनट में 500 मीटर चल रहे हैं, आपका सीआरपी 1 से कम आ गया है और आपके यूरिन में माइक्रो एल्ब्यूमिन नहीं है, तो आपको मालूम है कि आप कोरोना से पूरे रिकवर हो चुके हो और डॉक्टर अशोक गुप्ता से डिबेट कर सकते हो कि भाई मेरी सर्जरी करो, मैं रिस्क लेने को तैयार हूँ. That's all for today. Let me thank Ashok ji to be here with us. It was wonderful listening to you and your experience, and I'm hopeful by 25th of March you should be able to get your knife back and operate. Thank you. Namaskar.
Thank you,
Keep
Dr. K. Thank you.
Med Talks with Dr. K.K. Agarwal. Stay tuned and we'll be back tomorrow 7 p.m. with another show. Namaskar.
Thank you. Thank you very much.